Coronary Angiography. This talk will focus on coronary arteriography, which has become the main activity and concern of the cardiac catheterization laboratory. Patient selection for coronary artery bypass grafting and the design of the procedure for individual patients depend on coronary anatomy, so cardiac surgeons must be able to interpret coronary angiograms. Furthermore, since coronary angiography is an imperfect tool and carries risk, surgeons should be aware of the limitations as well as uses of this diagnostic technique. This requires a familiarity with some of the technical aspects of the procedure that I will review with you now. Selective coronary arteriography was developed by Mason Sones at the Cleveland Clinic in 1959. Melvin Judkins and Kurt Amplatz also made major contributions, designing most of the catheters used today for coronary procedures. Coronary arteriography is performed by injecting 3 to 12 cc of radiographic contrast into the coronaries. A beam of intermittently pulsed X-rays emitted from an X-ray tube located underneath the patient is aimed at the heart during coronary injection. The X-rays are completely absorbed by the contrast agent in the coronary lumen, but partially pass through the rest of the heart and strike an image intensifier positioned above the patient. This results in a recording of a two-dimensional silhouette of the coronary lumen. Each X-ray pulse is recorded as a single frame of a moving image. During coronary angiography, X-rays are typically pulsed at a rate of 30 frames per second, which allows for flicker-free representation of cardiac motion. The cardiac image can be displayed on a TV monitor or stored on cine film. The image intensifier converts X-rays to electrons, which can be digitized for post-acquisition processing, archiving, and imaging. The use of digital angiography with 1024 by 1024 matrix acquisition coupled with high-resolution monitors is becoming increasingly widespread and will entirely replace cine film in the near future. The adoption of DICOM, Digital Imaging and Communications standards, has galvanized this process. All of you can expect direct access to high-quality coronary angiograms of your patients on the computer monitor in your own office in the next few years. When you review these angiograms, you should be aware of some of the pitfalls that can lead to erroneous interpretation. Errors can result from factors related to operator technique, equipment, and patient habitus. Poor injection technique can lead to inadequate coronary opacification, which can be confused with a coronary stenosis. Proper technique involves injection of an adequate amount of radiographic contrast at high flow rates directly into the coronary with a catheter which is positioned coaxial with the ostium. Selection of an appropriate catheter may be a time-consuming process that can frustrate a hurried or inexperienced operator. Inexperience may also lead to weak and pulsatile injection. This problem can be overcome by use of a power injector for coronary imaging. Pressure injectors are especially useful in high-flow states, such as severe aortic insufficiency, where 15 cc or more must be injected at rates of 5 cc per minute or higher to achieve adequate opacification. Equipment failure can also lead to suboptimal imaging. X-ray tubes and image intensifiers deteriorate over time, leading to loss of resolution. Even the finest and best maintained equipment generally must be replaced after 7 to 10 years of continuous use. The most common pitfalls in interpretation are due to factors intrinsic to the technique. Coronary arteriography results in two-dimensional representations of moving and twisting three-dimensional coronary arteries. The lesions we attempt to define are frequently eccentric or slit-like and have a predilection to occur at bend points and bifurcations, which are difficult to image. On occasion, the lumen may appear hazy or gray, and it may be difficult to distinguish a hemodynamically significant lesion from a luminal irregularity. This is particularly common after angioplasty. Satisfactory imaging requires multiple views from different angles to avoid uncertainty due to vessel overlap and foreshortening. There are standard angiographic views that are useful in most cases, but on occasion, perseverance and creativity are demanded as the angiographer searches for a diagnostic view. The use of such oblique views creates other problems. As the angle of the X-ray beam becomes steeper, more tissue must be penetrated, and consequently, more X-ray is absorbed and less reaches the image intensifier. This results in whiteout of the image and inability to visualize the coronaries, particularly in obese patients. Coronary calcification also presents challenges. Calcium has a very similar radiographic appearance to contrast, so the degree of vessel narrowing may be underestimated in a heavily calcified coronary artery. Newer imaging techniques, such as intravascular ultrasound, are reliable means of quantifying luminal narrowing in the presence of calcium. Direct measures of pressure and flow using micromanometer-tipped wires and Doppler catheters are also proving to be useful in evaluating the hemodynamic significance of coronary stenoses. Angiographic views are defined by the position of the image intensifier. This is an image of a right coronary artery, obtained with the image intensifier positioned on the left side of the patient and angled towards the head, an LAO cranial view. The exact degree of angulation is displayed on the digital viewer, which helps when comparing views of the same vessel taken at different times. The LAO cranial view is generally excellent for profiling the bifurcation of the right coronary artery into the posterior descending and posterolateral PDA and PLA, which are the two most important branches of the RCA. The first two branches of the right coronary are the conus, which supplies the right ventricular outflow tract, and the artery to the sinus node. Neither of these vessels supplies the left ventricle, but they can be an important source of collaterals in the setting of coronary artery disease. Similarly, the right ventricular, also called acute marginal branches of the RCA, can be important sources of collaterals. The next image is a view of the RCA in the RAO view. This view minimizes foreshortening of the PDA and is useful for imaging collaterals arising from the PDA and coursing through the intraventricular septum to fill an occluded left anterior descending coronary artery, LAD. When we suspect that the LAD may be filling from collaterals, we inject extra contrast into the RCA, administer nitroglycerin, which augments collateral flow, and image for a prolonged period, 7 to 14 seconds. Please note that subtle findings such as faint filling of the LAD by collaterals are much better appreciated when you view a scene at 30 frames per second rather than on a still frame. Digital imaging, which permits you to loop the same scene over and over, is particularly useful in this regard. 2 or 3 views of the RCA are adequate in most cases, but other views, including the lateral or 90-degree LAO, which shows the mid-RCA very well, may be needed if the vessel is tortuous. This next image shows the left coronary in an RAO caudal projection. We generally shoot this view first because it minimizes foreshortening of the left main coronary artery. However, there may be overlap of the LAD and its diagonal branches with the ramus intermedians in this view, and there is significant foreshortening of the proximal circumflex. The LAD can often be distinguished from the diagonals and ramus in this view by the presence of a distal bifurcation, the so-called anchor that wraps around the apex of the heart. In addition, the LAD gives rise to septal branches that take off at right angles to the main vessel. Finally, the systolic motion of the LAD towards the circumflex helps distinguish the anterior vessel from the lateral vessels. The circumflex overlies the coronary sinus, and so can usually be identified after the coronary sinus is opacified during the venous phase of the angiogram. The best way to identify the branches of the left coronary is to go to the next view, the LAO cranial. In this projection, the anterior vessels are seen on the left side of the screen, while the posterior vessels are on the right. The left main is often obscured in this view, but you can clearly see the takeoff of the diagonal branches from the LAD, and can also appreciate that the circumflex courses posteriorly. You can also appreciate that both the diagonal branches of the LAD and the marginal branches of the circumflex supply the lateral wall of the heart. The best view to evaluate the bifurcation of the distal left main into the LAD and circumflex is the LAO caudal, which is shown next. This projection is usually called the spider view by cardiologists, since the left main looks like the body of a spider, while the LAD is the left leg and the circumflex is the right leg. Finally, the epicranial view is used to visualize the LAD. This view defines the origins of the diagonals very well and is useful for interventions. Angiography of vein grafts usually does not require multiple oblique views, but angiography of the left internal mammary artery requires several views. The LAO-cranial or lateral are good views to demonstrate the relationship between the lima and the sternum, while the aureocaudal and epicranial views are good for evaluating the distal anastomosis. The left radial artery is a convenient access site for imaging of the lima and can be used with a 6 French sheath for PTCA and stenting. This is an example of a severe lesion in a vein graft to the marginal branch of the circumflex. This patient had refractory angina and also had a severe lesion in a saphenous vein graft to the LAD. The patient was an elderly diabetic with renal insufficiency and prior CVA who was a poor candidate for reoperative CABG. This case typifies the value of hybrid revascularization procedures. We stented the vein graft to the marginal, and the patient subsequently underwent mid-cab with anastomosis of the lima to LAD. On the left, you can see a balloon inflated in the stenosis, and on the right are images of the final result, with a widely patent vein graft to the circumflex. The selective angiogram of the lima performed the day after mid-cab reveals an excellent arterial graft to the LAD. The patient is now doing well and is chest pain-free nearly a year after the procedure. This patient did well, but you must not forget that there are important risks associated with cardiac catheterization. Death, stroke, myocardial infarction, anaphylactic shock, and vascular injury can all occur, but fortunately, major complications occur in less than 1 out of 1,000 cases. The most common significant complication is renal insufficiency. At least 5% of all patients undergoing cardiac angiography experience a transient rise in serum creatinine of 1 milligram per deciliter or more. diabetics with pre-existing renal insufficiency, and patients with multiple myeloma are at particularly high risk. Risk is reduced by adequate hydration prior to angiography and by minimizing the amount of contrast used during the procedure. Non-ionic contrast agents do not reduce the risk. Clinical judgment and good communication between the angiographer and others involved in the care of the patient are crucial to striking the right balance between ensuring patient safety and obtaining adequate diagnostic data in such cases. In general, the risk of cardiac catheterization correlates with the severity of the underlying disease. Of course, as illustrated in the last case I showed you, the sickest patients are often the ones that benefit the most from catheterization and operative intervention. Further progress resulting from the ongoing collaboration between cardiovascular surgeons and cardiologists in partnership with basic scientists and industry holds the promise of safer solutions to the complex problems of advanced heart disease.